20% of patients suffer for more than 5 years before a doctor correctly identifies what is destroying their health. Over 68% are initially handed a false diagnosis, often told their severe physical symptoms are purely psychiatric or a routine gastrointestinal issue. This staggering statistic from a recent cross-sectional study of 216 patients published on PubMed highlights a profound medical blind spot. Today, we are unpacking the physiological and emotional realities of adrenal insufficiency. A recent article from the platform My Adrenal Life titled, "What New Patients Wish They'd Been Told," struck a chord with me because it describes a condition that shifts a person's world overnight, leaving them with a body that no longer behaves predictably. Eloise, we frequently hear about cortisol in the context of wellness trends and stress management, but when the body stops producing it, the consequences are catastrophic.
The wellness industry has done a disservice to our understanding of cortisol. We are taught to view it as a toxic byproduct of modern stress that must be lowered at all costs. In reality, cortisol is a fundamental pillar of human survival. The My Adrenal Life article correctly anchors adrenal insufficiency in the failure of the HPA axis, which stands for the hypothalamus, the pituitary gland, and the adrenal glands. When a healthy person encounters a physical or emotional stressor, the hypothalamus sends a corticotropin-releasing hormone signal to the pituitary, which then releases a hormone called ACTH. That hormone travels through the bloodstream and tells the adrenal cortex to pump out cortisol. It is an intricate, highly sensitive feedback loop.
That sounds like a straightforward supply chain. If the adrenal glands fail, the chain breaks and the entire system collapses.
The chain shatters completely. Primary adrenal insufficiency, often called Addison's disease, occurs when the adrenal cortex itself is destroyed and can no longer produce cortisol or aldosterone, regardless of how much ACTH the pituitary sends. Secondary and tertiary forms happen when the signaling from the brain fails. Regardless of the origin, the body loses its ability to maintain homeostasis. Cortisol regulates blood pressure, balances blood sugar, modulates the immune system, and dictates energy availability. Without it, a simple viral infection, a minor surgical procedure, or even extreme emotional shock can trigger a fatal adrenal crisis characterized by hypovolemic shock and cardiovascular collapse.
Let us look back at how the medical community first identified this failure. Thomas Addison, a physician at Guy's Hospital in London, published a monograph in 1855 describing a mysterious and fatal condition. He was initially trying to uncover the causes of pernicious anemia, but stumbled upon a completely different pathology.
Addison studied 11 patients who suffered from profound weakness, anemia, and a distinct darkening of the skin. His 1855 report on the constitutional and local effects of disease of the suprarenal capsules was groundbreaking because it was the first time anyone suggested that these small glands sitting on top of the kidneys were essential for life. In his documentation, Addison noted symptoms like general languor, remarkable feebleness of the heart's action, and irritability of the stomach. In Addison's time, the primary cause of this adrenal destruction was tuberculosis. Today, in the developed world, it is predominantly an autoimmune disease, where the body's immune system mistakenly attacks its own adrenal tissue.
John F. Kennedy is perhaps the most famous historical figure to live with Addison's disease. His energetic, youthful public persona starkly contrasted with his private medical battles, which involved severe fatigue, frequent hospitalizations, and the hyperpigmentation that Addison described. This brings us back to the diagnostic delay. If the symptoms are as severe as cardiovascular feebleness and profound fatigue, why does a study of over 200 patients show that most see at least 3 physicians before getting an accurate answer?
The early symptoms are insidious, nonspecific, and tend to develop very slowly. Fatigue, dizziness, nausea, and weight loss do not immediately point a primary care doctor toward a rare endocrine disorder. The National Institute of Diabetes and Digestive and Kidney Diseases notes that adrenal insufficiency affects a very small fraction of the population. Consequently, a doctor is far more likely to suspect depression, an eating disorder, or a chronic viral infection.
Furthermore, standard blood panels might show borderline low sodium or slightly elevated potassium, but these are often not dramatic enough to raise a red flag until the disease has progressed significantly. The patient is often sent home with antidepressants or antacids, while their adrenal glands continue to fail.
That creates a profound sense of medical gaslighting. The patient knows their body is failing, but medical professionals tell them their blood work is mostly normal. By the time they receive a diagnosis, they're often in an emergency room experiencing an adrenal crisis marked by plummeting blood pressure, severe vomiting, and loss of consciousness. The testing required to catch it early seems straightforward, though.
The initial testing is simple but rarely ordered. A morning serum cortisol test, checked alongside a baseline ACTH level, can indicate a problem. To confirm the diagnosis, endocrinologists use an ACTH stimulation test, sometimes called a synacthin test. They inject synthetic ACTH and measure the cortisol response at 30 and 60 minutes. A healthy adrenal gland will respond with a drastic increase in cortisol. A damaged gland will show little to no response. But unless a doctor specifically thinks to order this dynamic testing, the disease remains hidden.
The emotional toll of that journey is immense. The My Adrenal Life article emphasizes the grief that accompanies the diagnosis. Patients feel relief that their suffering finally has a name, but that relief is quickly overshadowed by the realization that their life has permanently changed. I want to challenge the perception of the treatment, though. Medical literature frequently states that hydrocortisone replacement therapy is a straightforward fix. You lack a hormone, so you take a synthetic version of it. Why does the article stress that treatment does not recreate normal physiology?
Because handing someone a bottle of pills does not give them back a functioning, intelligent HPA axis. In a healthy endocrine system, cortisol secretion follows a precise 24-hour circadian rhythm. It peaks sharply in the early morning, often before you even open your eyes, to prepare your body for the demands of consciousness. It then slowly tapers off throughout the day, reaching its lowest point at midnight to allow for restorative sleep. Furthermore, a working adrenal gland micro-adjusts cortisol output minute by minute in response to sudden stress, exercise, or a drop in blood sugar.
A static oral dose cannot replicate that dynamic responsive oscillation.
It cannot. Patients typically take immediate release hydrocortisone 2 or 3 times a day. This creates unnatural spikes and drops in hormone levels. A study published in the Proceedings of the National Academy of Sciences by researchers at the University of Bristol demonstrated this exact flaw. They found that standard cortisol replacement therapies fail to mimic physiological hormone pulses. This unphysiological delivery is associated with impaired working memory, poor sleep quality, increased cardiovascular risk factors, and chronic fatigue. The brain and peripheral tissues expect a smooth, continuous rhythm, not a sudden flood of synthetic hormone followed by a
The Bristol researchers highlighted that timing cortisol therapy to better replicate normal human secretion patterns resulted in significant cognitive improvements, particularly in working memory under high demand. This exposes a massive gap in how modern medicine views chronic illness management. We assume survival equals a return to normal function. The reality for someone with adrenal insufficiency is that their body is constantly running a manual override on systems that used to be automatic.
That manual override is utterly exhausting. Patients must constantly calculate their energy expenditure, they have to anticipate physical and emotional stress, and manually increase their medication dose, a practice called stress dosing, to prevent a crisis. If they get a simple stomach bug and cannot keep their medication down, they require an emergency intramuscular injection of hydrocortisone and immediate hospitalization to receive intravenous fluids. The mental burden of managing this condition is relentless. You are essentially acting as your own pancreas or adrenal gland, calculating inputs and outputs constantly, yet it remains completely invisible to outsiders.
The invisibility aspect is fascinating and cruel. The author of the My Adrenal Life piece points out that a patient may look healthy, hold down a job, and appear functioning while internally their body is struggling to maintain basic stability. Society reserves its empathy for visible disabilities. When a disease hides beneath the surface, the patient is forced to continually prove they are sick.
The societal expectation is that if you do not look sick, you must be capable of operating at full capacity. This forces patients into a defensive posture, where they are repeatedly explaining their limits to employers, friends, and family. Over time, this necessitates a profound identity shift. You have to mourn the version of yourself that could stay out late, skip a meal, or push through exhaustion. Pushing through is no longer an option when your body lacks the physiological mechanism to handle the push. If you push a body without cortisol, it simply shuts down.
This shifts the conversation from a purely medical framework into a psychological one. How does a patient reconstruct their identity when their baseline of energy and capability is permanently altered by a condition that most people have never heard of?
They must learn a new language, specifically the language of their own body. The article beautifully articulates that patients must learn to recognize subtle signals and respect hard limits. Some individuals find stability and maintain highly active lifestyles, adapting their medication schedules perfectly to their routines. Others experience wide, unpredictable symptom fluctuations and find that working a normal job is no longer possible. Neither path is a failure of willpower. The variability is driven by biology, individual metabolism, and how well the synthetic hormones absorb in their unique digestive system.
We frequently fall into the trap of comparing chronic illness journeys. If patient A can run a marathon with Addison's disease, why is patient B struggling to work a desk job? This comparison ignores the physiological reality that no two endocrine systems respond identically to synthetic replacement. It places the blame on the patient's mindset rather than the limitations of the medical treatment.
This expectation of uniformity harms patients deeply. Current research in endocrinology is finally acknowledging the quality of life deficit associated with immediate release hydrocortisone. Scientists and pharmaceutical companies are developing modified-release hydrocortisone formulations. Drugs like Plenodrin, a once-daily dual-release tablet, and Chronocort, a delayed and sustained-release formulation taken at bedtime, are designed to better replicate the overnight rise and daytime taper of natural cortisol. These advancements show promise in reducing fatigue and improving metabolic profiles. But until these advanced therapies become universally accessible, patients are stuck managing a 20th century treatment protocol in a high-stress 21st century world.
Let us examine the cultural legacy of how we treat chronic invisible illnesses. We place the burden of adaptation entirely on the patient. We expect them to mask their symptoms and assimilate into a workforce that demands constant productivity and limitless energy. Adrenal insufficiency forces a confrontation with these toxic productivity standards. It demands pacing, rest, and rigid boundary setting.
It forces a person to value sustainability over output. The author of the My Adrenal Life article reminds patients that if their path takes longer or if their life looks different now, it does not mean it has less value. Society defines value by economic productivity and visible achievement, but chronic illness requires redefining value through resilience, deep self-awareness, and the quiet triumph of surviving a condition that would have been universally fatal just a century ago. The identity shift involves accepting that living carefully and intentionally is an achievement in itself.
The discovery by Thomas Addison was a medical triumph, but the lived experience of adrenal insufficiency requires a personal triumph every single day. The gap between medical survival and actual quality of life is where this struggle happens. It is a space filled with uncertainty, constant recalibration, and profound grief for a lost identity. Yet, as the My Adrenal Life article concludes, there is still room for a meaningful, full life, even if it operates on a completely different frequency than before the diagnosis. Recognizing the sheer biological effort required to simply exist with this condition should invoke deep respect both from the medical community and the general public. These patients are meticulously managing a complex biochemical balancing act every single day. The human body is a fragile ecosystem, and when its primary defense mechanism fails, the person must become their own shield, constantly calculating the cost of every action. Thank you, Eloise, for joining me to explore this complex physiological and emotional landscape. If this discussion resonated with you or helped you understand the silent battles of chronic illness, please share this episode with a friend so they can explore these hidden realities too.